Hello, everyone, and welcome. The NWRPCP has recently received some questions and concerns from paramedics and paramedic services around the term cease resuscitation. And through those conversations, it was determined that a quick refresher would be beneficial to ensure that paramedics are comfortable with this component of the medical cardiac arrest medical directive. So without further delay, I'd like to welcome you to our first rapid review, cease resuscitation, when enough is enough. This conversation will be focused on helping you make one of the most difficult decisions we face in the field, knowing when to stop. All right, let's dive in. So you've been working at cardiac arrest for about 12 minutes. The patient has multiple comorbidities. There's been no ROSC achieved. The rhythm is persistent asystole, and your end-tidal CO2 is sitting at 8. So what are you thinking right now? Should you keep going and complete a full 20 minutes of resuscitation? Or should you maybe consider that this resuscitation is trending in a futile direction, and maybe there's a discussion to be had about stopping? So the first and likely most common concern that we've come across is that paramedics have identified that the term cease resuscitation isn't technically in the medical directive, which therefore is putting them in a predicament of liability as it's essentially a gray area. However, if we look at the mandatory provincial patch point section in the directive itself, we can see that it is a mandatory consideration to patch early. And the example that they give is following the fourth rhythm interpretation, to consider a TOR if there are extenuating circumstances where the paramedic considers ongoing resuscitation to be futile. Now, the term TOR, or termination of resuscitation, is used here, which no doubt is causing a little bit of confusion because today we're speaking about cease resuscitation. However, in this context, cease resuscitation would technically be the more appropriate terminology, and we are continuing to advocate for a change to this language in the next edition of the guidelines. So let's now look at a couple of the key differences between the two terms and look at why it's important for paramedics to understand the difference between the two. So here we have a contrast between the two terms. Termination of resuscitation, or a TOR, is medical directive driven. It's tied to a very specific set of language or conditions to determine patient eligibility. It happens after a full resuscitation, so after the conclusion of your 20 minutes, when there's been no ROSC achieved and all the other criteria or conditions have been met. Cease resuscitation is different. This is a clinical decision made by paramedics during an active resuscitation. It is based on indicators of futility, and like a TOR, it does require a consultation with a base hospital physician. And most importantly, it can happen before 20 minutes. If we think back to the previous slide, the mandatory patch point speaks to the example of patching early after the fourth rhythm interpretation. However, this is just an example. By the time you acquire all of the most pertinent information that you need to make this decision, this might be occurring at minute 6 or at the conclusion of rhythm interpretation number 7. It's all dependent, again, on when the paramedics have a full appreciation of the clinical situation. The bottom line for differentiation between the two terms is a TOR is going to meet the defined criteria within the medical directive, where a cease is going to be dependent on paramedic clinical judgment and the base hospital consultation. During a resuscitation, you're going to acquire a series of all sorts of information. And sometimes that information is going to indicate that ongoing resuscitation or the resuscitation itself is not trending in a positive direction. If this is the case, we hope that you feel comfortable and confident to consider calling a base hospital physician to propose that all resuscitation efforts be ceased. This is a patient-centered recommendation based on evidence that maintains the dignity of your patient. Now, in the context of the medical directive, many of these patients may not meet your TOR criteria, meaning that maybe there was an initial shockable rhythm, or the end-tidal CO2 is sitting at 12 and is not necessarily less than 10. That's okay. That's why the BHP patch is required. We're not looking for paramedics to solely make these decisions of stopping resuscitation on their own. We're asking them to quantify the information available to them to determine the probability of the viability of the case, and then make a recommendation to a physician based on all of those findings. And this right there is where we're tending to see some in the practice across the region. Some crews are going to wait for the clock, meaning that they feel completely obligated to run a 20-minute resuscitation regardless of the information at hand. On the other hand, some paramedics are quick to recognize signs of futility a lot earlier and are opting to consult with a base hospital physician to discuss the appropriateness of ceasing their efforts. The goal in our region is to better align this decision-making and empower paramedics to confidently contact a BHP in situations where there is evidence of poor viability, when all the information has been assessed. So let's talk about indicators of poor prognosis. So we're going to start with scene and timeline factors. So was the arrest unwitnessed? Was there a prolonged downtime? Was there little to no CPR performed? Was there just a general delay to compressions? Are you facing a very prolonged transport time? These are all factors that, if present, are going to point to a lower likelihood of survival. Now, let's layer in the clinical picture. An initial rhythm of asystole is not a strong starting point, especially if that trend continues. End-tidal CO2 persistently less than 10, or an absent ROSC despite all of your good interventions, significant comorbidities, and the overall patient context, meaning caregiver wishes, family members, have they been informed of the situation, and are they on board with the fact that this may stop before they go to the hospital? No single factor is going to determine futility. It's going to be all about the pattern or the trend that matters. And as we're all aware, not every arrest is going to happen in a controlled environment, but sometimes the situation itself is going to limit what you can do effectively. Think about the operational challenges that you face: difficult egresses, confined spaces, prolonged extrications, very long transport times. We have patient factors like the body habitus that might make compressions or airway management difficult or next to impossible. And of course, resource limitations: not enough hands on deck, limited equipment, or the inability to maintain that high quality CPR that we need to achieve ROSC. These factors shouldn't necessarily make the decision for you, but they need to be considered alongside your clinical findings, not necessarily instead of them. But when they are present and the clinical picture is poor, a cease resuscitation is probably appropriate. So let's start to put this all together. So cardiac arrests with multiple poor prognostic indicators, no response to high quality resuscitation, and a clinical picture that suggests low likelihood of meaningful survival, well, that's your cue. Consider patching early. There's no reason to wait for a full 20 minutes before reaching out. And again, you're not alone in making this decision. We encourage you to use your medical support. When you patch the OMC, be clear and structured. We recommend that you consider the ISPAR to better formulate your thought processes. We want to make sure that all of the pertinent information available is conveyed to the physician so that they can make an appropriate determination of what happens next. We want to make sure that we're communicating the downtime. What was the presenting rhythm and what is the trend of that rhythm? What are your ETCO2 trends? And what interventions have you completed? So for example, for a patch, we're going to reach out and start it off. Hello, Dr. Savage. It's primary or advanced care paramedic so-and-so working out of, say, Kenora. My OASIS number is 123XYZ. I'm calling to recommend a cease resuscitation. We're currently working on a 90-year-old VSA patient who is a prolonged unwitnessed arrest. The patient was found and remains in an asystolic rhythm. Her airway is secured with an iGel and her end-tidal CO2 is less than 10. We have not achieved a ROSC after 7 or 8 minutes of resuscitation. And based on the indicators of poor viability and in consultation with the family members on scene, we feel it's best to cease our efforts if you are in agreement. This degree of clarity supports good decision-making between yourself and the physician. So let's review a couple takeaways. A cease is not the same as a TOR. It is with respect to what we're looking to achieve, but there is a significant difference in terms of the legal structure and intended purpose. Knowing the difference is important for paramedics to comprehend. You can recommend a cease before 20 minutes with BHP support. We want to look for patterns or trends of futility, not just a single finding. Look at seam and timeline factors, clinical and physiological factors, and those extenuating circumstances to determine the viability of your patient. And if you're in doubt, consider patching early to have that consultation. Knowing when to stop isn't about doing less. It's not a reflection of your efforts. It's about making the right decision for the patient and for the care that we provide. I'd like to thank you all for your time today. If you found this rapid review on ceasing resuscitation valuable, we invite you to share other suggested topics for future sessions. Until then, stay safe, and we'll see you all again soon. Thank you.